So we're back for DBT treatment from a developmental lens. Okay, so let's go to the next slide. Linehan talks about DBT in a nutshell, so that's why I called it Nutshell Treatment Strategies. So this is all from Marshall Linehan's book, Cognitive Behavioral Therapy for Borderline Personality Disorder, that was published in 1993. But I'm adding the developmental lens part. So the therapist creates a context of validation. That's the most important part. What Linehan first found that when she started doing treatment with this population is that they couldn't do cognitive behavioral therapy because it's fairly harsh. Cognitive behavioral therapy says, follow this plan and you'll be fixed, or you've got to stop doing this, you've got to change your behavior. And what she found is you have to do acceptance strategies first, because most people with borderline personality disorder can't hear anything about change without feeling like they're bad or there's something wrong with them. So you have to start with a beautiful context of validation. And you basically teach them to reduce negative, maladaptive behaviors, suicidal gestures, thoughts, and behaviors, and replace with positive ones, such as increasing positive experiences and building a life with living. Okay, next. So then the first thing you do is try to create a commitment with the client. They're in pre-treatment until the person makes a commitment to change the problematic behaviors. And you don't have to take a full, I've had people say, I can't do this part, but I can do this part. So you don't have to have a firm commitment, but you have to have a fairly weak agreement. And then you create an agreement between the client and the therapist about what you will do and what they will do.
And that's a continuous process.
Yes, it continues to be, you have to recommit. And I've had people who have a terrible breakup, say, or something that happens, and they are back in pre-commitment. So you kind of assess, is this person doing their skills? Are they filling out their diary card? So there's a diary card, is a monitoring system where you keep track of your emotions and your problematic behaviors and the skills that you've used. And you establish that relationship. So the relationship is key as far as the reinforcer for the changing behaviors. So go to next slide. A client is told that once the relationship established, her change is essential to maintaining that relationship. So you say, I accept you just the way you are, but we've got to have some kind of change in order for me to be an effective therapist so that I can continue working with you. To continue in ineffective therapy is unethical. DBT has been called blackmail therapy because the client is willing to put the relationship on the line for change in the patient. So
Wait, explain that to me. Why is that called blackmail?
So you're basically saying, I can't just stay in this relationship without expecting something from you. It has to be that you're going to make some kind of change in order for us to continue. But the relationship is bartered for change.
That's what it wasn't clear. All right.
Okay.
So
Yeah.
now it's clear.
Mm-hmm. Okay. Now the term dialectical behavior therapy is, Linehan stole most of this treatment. She put it together, and she deserves a lot of credit for that, but it actually came from Michael Bassages. Do you know, have you heard of his?
Yes, of course.
Yes.
From
So
who?
he
Michael Bassages.
Oh, Bassages, yeah.
yeah.
Who's one of the early members of this group.
Right, I mean, I know him. Where is he now? Well,
Yeah,
that's a
I don't
different...
He's
know.
in Portugal.
He's in Portugal? Oh, really? Well,
Patty, where is he?
Yeah, come on.
he
That's all excited.
do you remember the name of the book that he wrote?
Yes,
It was,
Dialectical
okay,
Thinking.
Dialectical Thinking, right. So she took
Actually-
that from his book, and I don't know that it's cited very...
Rick Richardson and I edited a lot of that.
Oh, okay. Yeah.
Just so you know, we're all connected.
Mm. Anyway, so...
Multiple paths.
Right, multiple paths. So dialectics...
And he was at the ed school.
Yeah. Comes from the Hegelian philosopher who talked about dialectical thinking of, it was, the action, reaction, synthesis, that finding a synthesis between two poles. So dialectics is, the two poles are change and acceptance. Validation and problem solving are the two ends of the teeter-totter. The therapist exerts control of the therapy and helps bring the client to a greater sense of freedom.
I'm going to interrupt again.
Yeah.
In Heller and Piaget, we're dialecticians, and it's explicit that stage change is a dialectical process.
Yeah, I also think that
That's in
subject
the
object
58.
is the
It's in the
is
58.
a dialectical
It's
process
in the 58 book, and it's explicit. And these old people never credit in Heller and Piaget.
Anyway, so the thinking in Linehan also was influenced by Zen Buddhist thinking, and so she uses cones a lot in the therapy. So it's encouraged to think both and versus either or, and the therapy is about understanding higher order complexity. You name the two sides of the dialectic so that you can then make that as an object, that the pole becomes then something that can be acted upon versus the one side or the other. So the first stage is to work with validation. That's you want to establish. She talks about in her book that validation is the behaviorist's way of forming a relationship. She thinks in terms of behavior. So what do? You validate someone. You say, I get it. I understand where you're coming from. You find the wisdom, correctness, the kernel of truth in the client's suffering. So, if somebody comes to you and says, I don't care about living, all I want to do is die, you can say, gosh, you must be in a lot of pain to think that that's the only solution to the problem that you're having. So you don't try to talk them out of it or tell them they're wrong. You pick the kernel of truth that is in the core issue that they're talking about.
What Tom Guttal would say when he's working with paranoid and manic depressive patients, if I were in your shoes, I would feel the same way.
Yeah. Mm-hmm.
Yeah, and it's the most important statement in alliance building is to recognize the validity of the suffering.
Yes. So the important piece too is that you can't talk to them about change without validating their self-concept and experience.
Right.
And another thing is to work with, sometimes the therapist might have a view of the person that's way outside their self-concept, so you have to be careful to offer that until the person can accept it. You can't just say, oh, I see you as being really successful, and that would be great, but if the person can't even hear that because it's outside their awareness, then it's kind of not a useful intervention. Okay, so the next one. Linehan talks a lot about shame and judgment, shame versus guilt, and shame and judgment. So the issue, we talked about Buzz Lightyear earlier, how he had that narcissistic injury, and so one of the issues that most people with borderline personality disorder or with addictive behaviors, or whoever's using this treatment, is that they feel very exposed when they get clear on what it is that's happening, what they're doing. So you have to be really careful to do your observing and describing in a very non-judgmental way that holds the person, even though their behavior is something that you want to help them change. So you do non-judgmental observations as much as possible. So she talks about judgment is adding an emotional kernel of, how could you do this? Or, you want to really work on not doing that. You work on being very validating about why the person would do it, but yet it's not necessarily the best thing for them. So, okay, so then once you've established the therapeutic relationship, you can talk about what there's. Can you go to the next one stage? Yeah. So the main core of DBT is being able to do a behavioral analysis of the target behavior. So most people who are in stage 1, and now I'm using stages here as far as this is DBT stages. So she's got stage 1 and stage 2 of treatment. Stage 1 is about having suicidal behaviors, self-injurious behaviors, therapy interfering behaviors, and behaviors that are causing problems in living, such as addiction, eating disorders, drinking, all those behaviors that don't get you your goals in the long run. So what you do is establish a relationship. You get the person to go into group and individual therapy, and then you start doing these things called chain analysis, which is the same as a behavioral analysis.
Can you explain why she used groups and psychoanalysts were never into why personality disorders really require groups? I've never heard that from anybody.
Well, I mean, we know that in AA, most people, often when they're in their stages of drinking are have a personality disorder and accompanied with that. They do well in groups. Linehan, what she found is just that she did her treatment. It was easier to teach the skills in a group setting. I don't know that she specifically set out to prove group versus individual, but I know that the evidence-based research that she did always has once a week individual therapy and once a week group. So the person gets 2 forms of therapy per week. And that's what and she had people with borderline and no pharmaceutical for the first treatment was just pure behavioral therapy with not even using medication. Now she says people can use medication and that's just an adjunct piece. But
can I answer?
Yeah, sure, go ahead.
There was early work with DBT with criminals. And criminals just simply wouldn't trust therapists. They were authorities and they were part of the system. And they did trust other prisoners. They didn't think they were, they didn't think that they weren't power struggles, but the therapy groups weren't made with the people on the same unit. But they were prisoners, so that they, just like AA, you're not allowed in to do observations of AA because you're not one of the people suffering. So they lack a valid ear.
Mm-hmm.
You have to have a valid ear. I think it's about the valid ear.
I also think that there's social reinforcement for being effective. So if you know that your friend is going to notice in group that you didn't do your homework, it might give you more social reinforcement to get that homework done because you don't want to be embarrassed in front of your friend. So then there's you're adding both the social reinforcer as well as the problem, the fact that your therapist wants you to do it. I think the social is very strong. And then also in the long run, you can form new social groups because many of these people have really poor social conditions that they come from. So if you're living in a family where people are drinking or using drugs or abusing, and then you go to your DBT group and people are acting better, you might then think, okay, I want a social group that's more like my DBT group rather than my family. So then that gives them a different perspective on what social groups can be like. Okay, so next slide on chain analysis.
Next one.
No, that's it.
No.
That's all.
Yeah.
There.
Yeah. So when you do the chain analysis, it's just that you call it the bubbles or whatever you fill in. So I can't remember your name. You were asking me once about do we have to worry about people's vulnerability. So if somebody say they end up doing
Her
their
name
problem.
is Miley.
Miley, okay, yeah, you were asking me about that. So you want to look for vulnerability factors. Did you have enough sleep? Did you drink the night before? Did you have a fight with your boyfriend? What was it that prepared you to have a slip in the behavior? So you can start this chain by just going to the arrow that says behavior is where the problem behavior occurred. I cut myself. I drank alcohol. I had unprotected sex. Whatever the issue is that is the problem behavior.
But it's a chain, and that's from verbal behavior, Skinner, in 47.
Yes. So you're going back and asking links on what did they feel, what did they think, what happened, and then often there's a prompting event. Yeah, go ahead.
So it seems like this graph is pretty easy for a person to do on their own. What would you say, is it easier for them to do and more effective for them to do on their own, or with a therapist? Which way would it be better?
Well, it depends on the client. So when you meet with a client, like some clients are absolutely like, I don't know. I start in the morning and I'm not going to drink, and I end up drinking. I have no clue what happens. They really aren't self-aware enough to be able to fill in a chain. But other people really are much more self-aware. Oh yeah, I knew exactly when it happened. My boyfriend called me, and we're broken up, and he triggered me, and I felt terrible about all those things. And then before I knew it, I was covered with shame, and then I did this. So I'll show you a filled-in one, and
so
the
it
next
depends
one.
on the level of self-awareness.
Yeah.
And stage of development.
Right, yeah. But you can, so one of the things I found is that if there is early trauma and the person is sort of like back in their implicit memory, they might not even be able to fill this in. I mean, I had one person just go, I don't know. I just have been dissociated for 2 days, and I can't feel, I can't think, I don't know what happened. And then usually we can go back to what prompted it. I mean, it's weird stuff. I had one woman who said that she accidentally got poked by a pin when she was doing some beating, and it like took her back to being a baby and being poked with pins or whatever, and she was like gone. She couldn't remember anything. She was back to a very regressed infant state for like a week before she really could get out of it and come back to therapy. So that's another thing, is you keep in touch with people to find out what where they are. Like if they don't show up, you as the therapist are supposed to continue to like pursue and figure out what happened, and then you do a chain on that.
So when you're talking about vulnerability, you might be, I'm trying to do this for my 7-year-old whose father died last year, and she's been melting down regularly ever since. So melting down is the behavior.
Okay.
Vulnerability, it seems to me, far more likely to happen when she's tired,
Yes.
hungry.
Right.
Okay, and then the prompting event might be something like her grandfather telling her to sit down. It could be something really small that's kind of shaming,
Yes.
And then links, what are links?
The links are emotion, thoughts, the things that get you from the prompting event to the behavior. Like, this is where you can intervene. Why don't we just go to the next slide?
Okay.
So here's a filled-in one of the person. So the vulnerability factor is the person drank alcohol the night before. She saw her ex-boyfriend with another woman. The links are things like her thoughts. I am so lonely. I miss him. Then she went to, I'm just not lovable. No wonder that he left me. I screwed up. How can one be so stupid? I am awful. So then she ended up going into the feelings. So there's the shame, guilt, feelings. So it goes from, it goes down to the bottom and then back up. So if you see, she got into self-hatred, got into high physical arousal, thoughts are, I can't stand it anymore, and then did her problem behavior, went home, cut herself. And then she had, the short-term consequence was relief, which is reinforcing with the having the cutting. and then had to go to emergency room, felt like a freak, had shame, and then the long-term consequences, emotions of sadness, guilt, and shame. So when you do a chain analysis like this with a person, you then try to look at, okay, what if we could have intervened back on after the prompting event with, I'm going to go home and I'm going to call my good friend, I'm going to call my therapist, I'm going to try to get people to tell me that I am lovable. I mean, it may be that she shifted her whole chain then so that she didn't have to do the problem behavior. So that's what we're looking at. What are ways where you can intervene? And you do this over and over and over in the therapy with the person. So sometimes you'll see chains that are exactly the same over and over. And like, okay, how many times do we have to do this? Can't you call me here before you get the razor blades out? Can't you, let's do something else. And I've had people where when we knew ahead of time that there was going to be a vulnerable thing, we planned a phone call. So then, like, in this case, it was seeing the ex-boyfriend with another woman. She probably wouldn't have known that. But if the person knows that the prompting event is going to be, I have to attend a function with my ex-husband, and I always get triggered when we go to those events, I can prepare with them, okay, you're going to see your ex-husband, how can you plan ahead? How can you, make sure that you call me or you bring your positive affirmations or bring your best friend or you do something that will keep that bad behavior from happening.
I have a comment.
Yeah.
I think that the pattern of the links is very similar no matter what the bad behavior is.
Mm.
And as opposed to most therapists, this is when they start standing in judgment. They say, I don't want you to do this, or they say, why did you do this? They start questioning. They put the person into self-blame versus other blame. And you find this with people who work with depressive people. But remember, in personality disorders, there's not a lot of insight. And what the chain is you're addressing the automatic nervous system chain of events,
Right.
not the cognitive. And this is one of the big advances. This is why it works with personality disordered people. You're not putting them on the spot. You're not standing in judgment. And you're realizing that there's this automatic nervous system interfering with the thought.
Yeah.
And so you're trying to raise the probability of the activating the frontal lobes. I think, the science of this is very clear. And I'm just telling you, the reason therapy is so low and why psychoanalysts or dynamic therapists won't treat personality disorders and why we have a prison full of people who are suffering from this, no one wants to treat them. They're unpleasant people. And I think that you have to say, you have to have if you've worked with autistic people the way you and I have, we've gotten that out of our system. We know that it's not their fault. And we don't have those tendencies to stand in judgment. But I think most therapists are. When I did the study at ABBA a few years ago, I found that all the behavioral therapists believed in free will. And at SQUAB, no one believed in free will. Society of Quantitative Analysis of Behavior, the Herrnstein people, and the Racklin people.
You had a question.
So I think that in this chain of event, I think that it's kind of huge and a bit overwhelming to expect the person after the prompting event to suddenly have to know that they need to call, they need to make these actions. I think that just telling them to do is not enough of a reinforcement. Because one thing we know about behavior is that habits are stronger, and them falling back into their attempts of cutting themselves or abusing is a habit for them. And I think one of the things that therapists could do, and this works very well in AA, is to make the intervention a habit already. Like in AA, you have to call your sponsor, 3 alcoholics every day, for example, and you have to establish a relationship so that when the prompting event comes, when you are down, when you feel like drinking again, it's already a habit for you to call these people, right?
Yes. So you're exactly right. And so this chain analysis say it might have happened like the first or second week, but what you'll do is you get the person in the habit of contacting you as a therapist and doing their diary card, which is keeping track of what skills that they could use when they have specific, like the tip skill of, like, if the person at the point where she was at high physical arousal, if she could have said, okay, I got to put cold water on my face, I just got to stop trying to solve this problem, I just got to accept, and then use that skill, she probably would have been able to stave off the problem behavior happening. So you're forming it in a habit with the repeated therapy and the treat. This is over 6 months of time. So you'll be able to see these chain analysis over and over, in which sometimes you just sit and do an alternative. Like, okay, what if we could have done this here? And then the person is supposed to carry it around with them, of like, okay, this is the same thing that's happening, what am I supposed to do? And then they look at their sheet that says intervention, this is what I can do, I can use this skill, I can, but you're right, we do. And with people that won't call, because some people won't call, you do end up planning a behavioral phone call. I had several
on a regular
like
basis.
Reinforcing.
Yeah, especially if you know when they're more vulnerable, of like, so they're required to call you. So then in therapy you say, hey, this happened, you never called. Like this chain right here, I would have immediately said to her, why didn't you pick up the phone when you were, in that feeling of thought, of what?
I would not say.
What would you say?
I would say, gee, I understand how hard it is to call. And I would always make it an empathetic. Let me tell you that the highest rate of suicide is among borderlines, and there are various kinds of borderline personalities. The ones that have they have the shoving away critical ones who fight with everybody. They're not the suicidal ones. It's the self-harming ones and the self-blaming ones.
But the part about, I agree with you that you would validate always first. I didn't mean to say that I would have immediately done that, but I would have validated, okay, I get it that this happens, but did you realize that you would have had that I would have been there if you had tried to call?
I wouldn't even say that.
Well, we want to set up an agreement that
I know, but I would say I would start with I would do the empathetic statement first.
Of course, yes, the validation.
The validation, and I would make sure it sank in.
Yes.
Before I would say, I wouldn't even say I am available. I wouldn't even remind them, because what we found with autistic kids is when you pay attention to bad behavior, you get more of it. And so what you want to be paying attention to is it never reinforces suffering to mention, gee, I understand your suffering and how hard it is to make a call.
Oh, yeah.
That does not reinforce suffering.
But eventually, at some point, you want to remind them that this is part, because it's therapy interfering behavior to not use your therapist when the therapist is available. So that becomes then a chain that you do on that piece
I understand,
too.
but I'm saying, what we learned from Ivar was people who were acting as helpful, reinforcing. And we had cutting and stabbing and eye gouging and head banging. So we had all the same kinds of behaviors, and anyway, I just want to mention. I mean, we got trained up pretty early of not reinforcing these behaviors and trying to save people right away.
Right. No, you do absolutely validation, acceptance, hey, and then it might come out as a irreverent kind of thing of, hey, what am I, chopped liver? You didn't think of me? Something to make them laugh.
But that's about you. That's about you, and it's all right always to talk about yourself. Yeah, I remember one person I knew. I said, "Hey, should I join you in this?" Which made a joke of it, right? But it showed empathy. Okay, so I'm agreeing with you.
All right. So then, we're on steps in changing problem behavior. Okay. So you do your chain analysis. Find out what is causing the problem behavior to reoccur, especially if you're seeing the change, you're seeing the behavior over and over and over again. I mean, I'll be honest with you, the most difficult ones, and I think Linehan would say the same thing, is when dissociation is deeply buried and you can't get the person to explain what it is. It's so implicit. I have a client right now. We have worked so hard on shopping. She has a shopping addiction. And what happened was she was extremely, when her family didn't pay attention to her except for giving gifts because they were wealthy and they were busy and they didn't have any time to spend with her. So as a child, she was left, but then there would be this nice little package, of like, oh, we've been gone for 2 weeks, sweetie, we're with the nanny, but here's a package. So now she's, the only thing she does when she's stressed is dissociates and finds out that she's bought things online. And then, but she doesn't remember the purchases most of the time, and she won't return them. We've talked about, can't you just get your wise mind self to be able to return the purchases? No, this part of me really wants this thing. And so the therapy is about getting back to that original trauma of that is the rewarding thing for her. So
she won't return them because
the little kid part inside, or the regressed child part of herself, still says it's mine and I deserve it. And so she flips into these different states during the therapy, and it's like I sit and watch it, So
3-year-old behavior.
Right. So what I'm having.
It's not sentential. It's pre-operational.
Yes, I believe it is pre-operational, and some of it is even she has no awareness. Although later she's like, I can't believe my bank won't balance. I can't pay my bills, and she's got terrible financial difficulties. But there's a protection against me knowing all the pieces of her dissociation. So one of the things that Linehan does talk about is that you can use behavior even without knowing all the causes of the chain. So she does have a thing, and now I don't know what you're going to think about this, but this is Linehan, and I've used this in sparingly, but it's called you basically put the person on vacation. If you can't. If the therapeutic relationship is not going well, you can't get them to change, nothing seems to be working, you just say, let's take a break for a couple of weeks or a month or whatever, and I will pine for your return. But and you send them letters or send them emails, you keep in touch, but then you continue to say, for us to have a therapeutic relationship, you have to really be able to change. And even people who are dissociative, some will often respond to that because the whole self knows that it's better to be.
That's the transition from pre-operational to primary.
Okay, interesting, yeah.
Okay, I mean, a kid in primary school knows when they get the answer wrong. The pre-operational kid doesn't know the difference between reality and fantasy.
So what I found is that if the deficit is in pre-operational to primary, it makes sense that it does work better for those kids.
Yeah, of course.
But the abandonment ones, it does not work at all. They absolutely won't.
Go nuts.
I've had where they just fire me or they don't, so it doesn't so I have to be really careful about using that,
Well, that's why
tool.
stage adds
Stage
a
adds
very big,
yes.
There's the best example you've given where if you consider the state, you behave differently as a therapist.
Yes, yes,
And I think
exactly.
you should make this point very, very clear in your work. And I think if you stage the tasks that they're failing to solve and how you get them to solve it. With the attachment one, the fact that they can't access it, you can work directly on access. And what's wrong with the chain that you, what I would do is I would do a micro chain.
Okay.
I would go through it every event by every event and ask them to add more events as you go. I would write down all the events they can remember and then try to get them to fill in the ones in between. But I would really do it as a reconstruction, because what happens in the chain of events, who said it about in habits? Miley. In habits, often when you're training up a discrimination and you ask a rat, you have to train the rat to report.
Mm.
You have to actually train them to report, did I get this right or did I get it wrong? Should I be paying attention to smell or to touch?
Oh, okay.
And so if you go back to the, what's that stage? I can't remember.
Pre-operation?
No,
Or is
it's way
circular?
earlier. It's
Sensory
the
motor?
sensory motor stage. They can reconstruct.
Hmm.
And so I would suggest that as an intervention. I mean, if you can get rats and pigeons to report the sequence of events, you can get even people who have terrible time remembering things. They can be trained to literally remember by having them disassemble the chain.
Well, I'll work with that with my shopping addiction person because it's still a problem. Anyway, let's go on to the next one then. So
That's why I didn't put a time limit on it.
There's a half hour.
okay,
No, she has as much time as she wants.
Well,
okay.
you need to talk about that to the next.
I understand. They
Oh.
came late, they have to wait.
No.
It's not their fault.
I don't
No, I'm
care.
planning to be done.
I'm sorry, I didn't know we were late. So sorry.
Huh?
I'm so
No,
sorry.
they're not
I didn't
late.
realize we were late.
They didn't realize
So
because
I
I'm sorry for
understand.
interrupting.
Al didn't tell you. Come on, I have to blame
I
Al.
know, yeah.
You
That's
know.
always
You and Al know one another pretty well.
We do.
Yes. Yes.
Okay.
Come on, missing your flight?
Yeah,
Traffic
I'll
in
share
LA.
that with you, yeah.
So in the Linehan model, you're teaching the patient to be her own sort of case manager. You continue to instruct, and what I like about this therapy is that it is elevating the client to become an expert on her own behaviors and an expert DBT clinician. Basically, is that there's no power authority. It's a relationship, effective relationship reciprocity. And you can do, I mean, when you talked about the balanced communication is between we're both in this together, okay? Like, gee, I am having so much of a puzzle trying to understand your chain. It's really tough
Right,
for me.
exactly.
You know, you help me. I can't seem to get this piece where you dissociate. Do you feel like you can fill me in on that? Let's work on this.
Perfect.
So it's a problem solution thing with the client to understand what's happening in such a way that you're not trying to be an authority or better than they are. You have some experience on problem solving, but the client should feel that you are working together. And then the therapist also needs consultation. One of the most difficult things with these kinds of clients is that they can get you in your own weaknesses or your own places where you have your own trauma deficits. So, I mean, my DBT group helped me see with a specific client that I'll just tell, I myself have an adoption history, and this was working with another client who was an adoptee, and it wasn't until I took it to my consultation group when they were like, you are walking on eggshells and really, not pushing this client to really do what they need to do because you don't want to rock the boat for them because of your own, history. And so that's what a consultation group is able to do, is to get you to be a more effective therapist by getting you to see where your own blind spots are. So that's part of this treatment too. Okay, so let's go to the next one. The modes of therapy, yeah. So do you have that one?
Yeah.
Yeah, okay. Okay, so these are all the pieces that go in. This is the Linehan research pieces. So you have the individual outpatient therapy, skills training. You can have supportive group therapy in addition, like with AA, or you can have it as an adjunct, like a post-skills training. Telephone consultation, which is the in vivo moment to moment where you can actually be there for the client when they're having the crisis. And then you do the case consultation. Then ancillary treatments are things like psychiatry, you might have case management services, depending on what the person's needs are. And I found this cartoon that I thought was kind of interesting. The next one, yeah. So these are the parts to diagnosing borderline personality disorder. So you go through frantic efforts to avoid abandonment, unstable relationships with extreme idealization and devaluation, potentially self-damaging impulsivity, suicide attempts, threats to manipulate others, and chronic feelings of emptiness. So the DBT is to work on any one of these symptom type things.
I had a question. Do you ever get clients who are the anorexics?
Yes, I do have anorexics.
Could you make a comment on how difficult they have the highest rate of death of any clients?
So the most important piece that I do with the anorexics is just really get clear on, are you willing to stay, you can't allow your weight to go, so I name the weight loss where you go below the part at which you're metabolizing your organs, your vital organs, your brain, your heart, whatever, and usually a doctor can give an identification of what weight the person needs to be so that they're not at that stage, and I say that's the same as a self-injurious behavior or a suicide attempt. You have to maintain above that weight or we're going to have this intervention, which would be hospitalization. I worked with one woman, she had to have a tube inserted, so that you name it as the negative, the lack of
is that a is that a personality disorder, do you think?
I think it has something to do, definitely I've seen
it has a
with,
big component of narcissism.
Yes, mm-hmm. Yeah, it seems more like the not allowing yourself to have things. That's the other thing I didn't say. The chain analysis can be done both for positive and negative behaviors. So you can do it, your chain is every time your weight goes under this amount, or every time you skip a meal, or every time, as long as the person is willing to agree to what their problem behavior is. You can even do chain analysis on procrastination. Of like, oh, I walked by this desk that I need to clear off, 5 times and I didn't do anything about it. What was going through my mind, whatever. And so you increase the environment to the positive. So they can work, it can work reverse. Okay, so.
You have changed the slide?
Yep, change the slide, yeah. Okay, so I'm going to kind of go fairly quickly through these because a lot of them are on the treatment. So again, the dialectics, the therapist has to have skills to not polarize. One of the things that is so interesting is when I was at McLean Hospital, we would do these grand rounds where everybody had to sit, and you could always tell the borderline patients because in rounds, people would be, oh, this person really needs to change. They're not acting. You're fragilizing them. And the other side would be, oh my gosh, we've got to take care of this poor person. You're pushing them too hard. So the dialectic became acted out in the rounds meetings because that's how the...
Why you never want to see a resident.
But I mean, that one of the things that we started realizing doing DBT is that is what happens, and there is an agreement amongst. I mean, I haven't even scratched the surface on all this stuff with DBT, but one of the agreements is to allow for inconsistency between therapists. That you don't have to agree on. You have to agree on what the principles of the treatment and what you're doing, but the specifics regarding that client, sometimes either side of the pole can work as far as an intervention. So you have nurturing validation versus benevolent demanding. Benevolent demanding is kind of, come on, can I pull this behavior out of you? You have unwavering centeredness, but you also do compassionate flexibility. Okay, so you didn't bring your diary card this week. Let's work on that. Let's go for it for next week, but I'm not going to judge you. Okay, so the next one is you set your behavioral targets. Oh wait, I skipped one. Agreements. So you have your dialectical agreement, consultation with a patient agreement. These are some of the agreements that occur in between the therapist and consultation. So consistency is that it's okay to be inconsistent. Observing limits is your limits are not her limits. So if you're a young mother who's a therapist and you have a baby that's keeping you up all night, you may say, I will not take phone calls in the middle of the night. I just won't. I have to have them be taken by an answering service. And that's okay as long as you observe your personal limits. Fallibility agreement, we're all fallible. So the dialectical agreements are the two sides of the pole between the different therapists. Okay, so go to the next one. So, oh wait, did I skip? Oh, so your overall goal is to increase dialectical thinking and behavior patterns and increase the ability to think dialectically in order to transcend polarities. So basically this has stage built into it. It's taking this complex thing and looking at it as an object and being able to reflect on it, which requires the next stage up. Yes, and observing and describing are the mindfulness, the first two mindfulness skills that you learn in DBT is observing reality as it is, inner or outer, and then describing. So she builds in the very mindfulness builds in. Okay, so then, anyway, I'm going to talk about the dialectical tensions. Oh, did you do the next one? Yeah. So these are, overall, the client is taught to resolve the polarizations, which take extreme stances. So anybody who's learned back the cognitive strategies in reducing depression, it's very similar. You do cognitive modification of, the person says, this always happens to me. I'm such a screw up. And then you talk about, does it always happen? There's times when it does, when you've done effective work, so it's back, cognitive modification. Anyway, so just looking at the dialectical tensions, I'm going to go to the next slide, which, so this is the dialectical dilemmas, and this is where you see, okay, so there's the one on the bottom is called apparent competence. That's when you've got a person who's extremely, say, competent in a specific area, like they might be a great teacher, they might be a great therapist even, but then they hit something that triggers them, and then they're in active passivity or emotional vulnerability. So these two sides are extreme sides of a dialectical tension. So they occur through conditioning. You try to find out, like, okay, when did this happen before? And these are also called secondary targets. So you might have the primary target of that you're going to stop cutting, but your secondary target is let's reduce your emotional vulnerability so you don't keep getting every time your husband comes home and, you know,
Yells
ignores
at
you or yells at you, you're not so emotionally vulnerable that you go into this place of then agreeing and doing the self-invalidation.
What is active passivity?
Active passivity is, so if you get a person who, like, okay, so did I lose this? No, okay. Anyway, this is an example of a client, I think that Linehan talks about that. So you've got a borderline personality disorder client. She's driving along and she gets a flat tire. So what an active person would do is they would start getting on their phone and they would call for help and they would try to get a tow truck or they would try to fix their tire. They would try to solve the problem. This person feels so overwhelmed that she had a flat tire. She goes into emotional, amygdala hijack, can't think straight, starts self-injuring and calls an ambulance to come and get her to go to the hospital. So that's active passivity. The person's not solving the problem. They're actively passive in terms of being able to fix the problem at hand because they don't have the skill set at that time. So active passivity, it's when a person could solve a problem but they can't see how to do it.
Doesn't that happen in depression a lot?
Yes.
Isn't that one of the main things that happens?
Yeah.
In depression,
Mm-hmm.
they tune out and they can't deal with things. And that makes the depression worse because they fail.
Right.
It's,
So how is that different from just attention-seeking behaviors?
So attention-seeking behaviors, it depends on, the first thing I would ask is what is the reinforcer for the attention-seeking behavior? If the person is overwhelmed and they don't solve the problem, well, sometimes someone else might come along and solve it for them, because it's like, okay, you're sitting here on the side of the road crying and, somebody might stop or somebody might send the police over or whatever. So you can look at that as attention seeking, but I don't think that the person, they're just thinking, I don't know what to do. I don't know how to help myself.
No, but they're seeking for something
So
intentionally.
and one of the things
But I do know what to do if I hurt myself.
right. So that's a more
but that's more practiced.
right. It's been more practice.
practice.
It's more in their brain.
Right, right.
Remember, cutting is not the same as suicide. They cut their wrist, which doesn't kill you.
Right.
They don't cut their neck, which
Well,
kills you.
It
Right.
depends on the person. Believe me, I have had people who have gone real close to they're gambling on whether or not it's going to really do it.
Well, yeah, but now we're back to gambling addiction.
Well, okay, yeah. So you'll see. So one of the things that when somebody keeps doing self-injurious behaviors, they might do it deeper and harder or more dangerous places because it becomes sort of addictive in that way.
If you look at the people who die from overdoses, there are two things that are going on. One is the quality of the product they're getting is varied, and
Right.
the drug dealers actually killed people because the product is not
Consistent.
tested for potency.
Right.
So that's why if you get rid of street drugs and you have doctors give the drugs, the death rate goes way down. You don't have to do anything else. You just control the potency.
I want to respond because what you said about attention-seeking behavior. So DBT doesn't use that language at all. It doesn't use manipulate, attention-seeking. That's typically from other therapies that are putting their beliefs onto what the patient is doing. So what DBT says is that whatever the patient is doing in that moment is attempting to create the best possible outcome for what they know in their situation. So it might seem attention-seeking, but it also is all they know what to do at that time. They're doing the very best they can at that moment. So the terms like therapists will come together.
It's not about free will. And attention-seeking is free will.
yes, it says that if I do this, I'll get something back. This person is often saying, I don't know what to do, I just am reacting.
It
So-
takes a lot of responsibility out of their actions.
No, the responsibility, there are always real life consequences, and there are always situations. It's never about it's never about free will. And the hardest thing for young people to learn is there isn't any free will. And if you blame the person, you've ended the therapeutic relationship. It's just over. You can't reform the trust. You can admit to making a mistake, and that's the best you can do. But if you tell a patient, it's like people always don't understand that I have ADD, and they blame me for having it. And I said, what are you, nuts? I just go back. I said, you don't recognize ADD? You don't understand that it's biological? You think it's free will? Come on.
Well, it's like in AA, okay? So if you aren't aware that you have an alcohol problem, yes, you are responsible for the behaviors that say you drive and your child is in the back seat and you're driving drunk. That's irresponsible from one perspective. But it's also they're doing the very best they can with what they know at that time. Blaming the person and saying that they did a bad thing isn't helpful in this situation.
Punishment.
It's more of...
Because they're already drinking because they already think that.
Right. So it's more of like, let's look more carefully at what you're doing, and can I create an environment in which you have more capacity to not do that again? So the responsibility is not about moral at all in this situation. It's about able to respond. Are you able to respond?
Well, that's my definition.
Oh, well, must have gotten it from somebody.
Yeah, you did.
Okay, so should we go on to stages of treatment? So we talked about, then the stages of treatment are, you do the orientation, stage 1, you attain basic capacities, then stage 2, so this is where Linehan is different from other, like, more psychodynamic therapies. When I was at McLean Hospital back in the 90s, I'll say it just kills me to think what they were doing, but they would literally have people come into the hospital and they would have a 2-month window where they knew the insurance would pay for about 60 days of inpatient treatment, and they would go straight to their trauma and they would just regress these people and make them work on their trauma, whatever. But the person didn't have any skills. They didn't have skills, so they would go through this intense trauma treatment, and then they would be discharged after 60 days, and they would just go back in a regressed state, and they would try to kill themselves again. So what Linehan did is she said, wait a minute, this is not effective. Let's not do this anymore. So she said, you have to attain basic capacities before you do people's trauma treatment. Now that was revolutionary in the 90s to think like that. Now it's pretty much standard.
Psychoanalytic
How do you
institutes.
define basic capacities?
Basic capacities are, can you eat, can you sleep, can you get to your job, can you maintain functioning without continuing to self-injure? So you have to get out of stage 1. You have to stop self-injuring and stop doing therapy-interfering behaviors and problems in daily living, like that incapacitate you, like continuing to drink when you're an alcoholic or a drug addict, or so stage spending all your money. So stage 2 then is once you're capable of, and it's basically it's what the trauma therapists talk about, how you have to have one foot in the present moment ego state that's in the room with the therapist, and the other in the memory, because otherwise you're doing that the window of tolerance. I can't remember who's the guy that wrote window of tolerance. I can't think of his name, but anyway, if you go past your window of tolerance, you literally lost the patient. They're back in the memory. They're having a flashback.
Mm.
That's not effective. You're just re-traumatizing, and that's what the McLean people were doing. They were just re-traumatizing. They thought that they were helping, but they were discharging people. I mean, it's criminal when I think back on it. But
Just remember how many people who are becoming psychoanalysts fall apart.
Yeah.
It's extremely high. It's about 60%.
So anyway, her stages are different from stage development. So anyway, these are the stages of treatment in DBT. So please
Right.
don't, even though I'm using the word stage over and over because everybody uses that word. But anyway, so then you move to stage 3 and stage 4. Anyway, she has this thing called the House of DBT. That's the next. The next stage. Yeah. So Linehan has actually done a little video on this. So she talks about the first one, you're in severe behavioral discontrol and you're in the flames and, it's really hot down there and you feel awful. But the therapists are always, they can't be in the level 1 with you. They're more like in stage 2, looking down, trying to help you to bring you up. But they have to teach you how to get your hands on the, hot ladder and being able to climb up and being able to get, teaching you how to shift the contingencies and increase your skills to get to the place where you need to be. Then when you're in that next floor up, then you can do the PTSD work, the exposure therapy. I haven't even talked much about exposure therapy, but anyone who's a behavioral person knows about, it's basically a form of extinction. You're extinguishing the paired conditioning. So like one client, I'm going to modify this because it can be really, I'm trying to think of how to say it without being too graphic. But anyway, she was exposed to very difficult sexual abuse, and she had an extreme fear of lotion because the person that was sexually abusing her was using lotion at the time, so she could not even put lotion on her hands. And so one of the things we did is we tried doing exposure, like we're in the office, this is just lotion, it's not, and it's not going to harm you, whatever, teaching her. Well, I found out that you can't just do exposure until you do the early trauma work, because it wasn't until she told me why she was afraid of lotion that she could actually do the exposure work. So I won't go into the detail, but it had to do with her sexual abuse experience. So that is an example. And there's lots of examples where people have paired conditioning. So you can do exposure work, but you have to also do the trauma memory work in order for them usually to make progress with it. Otherwise, they'll keep flipping back to the memory, and even if it's implicit, it just stops it. The person will be like, I can't do this, So that's a sign they're not ready to do it. But okay.
What's more, what we have found out recently is what's happening in extinction is we're strengthening competing behaviors. We're not really extinguishing the pair. We're instituting the competing behavior.
Right.
But
And it's important to see it that
Yeah,
way.
it's very important to see it that way.
But the alternate though is a much more healthy.
Correct. But
Right.
what we're doing is what you said earlier in the 3-choice situation is an alternative to taking morphine. So that's what you're
Okay,
strengthening.
right. Mm-hmm.
You're strengthening the alternatives of sex, play, eating, etc.
Right,
Agreed.
and social relationships are some of the
Right.
most strongest reinforcers of all, if you can
Right.
get the person to actually have better social relationships. So,
It's like training a dog. If you tell them what to do instead of what not to do, it works better.
Right.
well, I'm noticing it's 4:00. Do you think I should keep going, or should I, when is the next person going to start?
It's fine.
Yes, Michael, you're supposed to start talking at 4:00. So.
Not me.
Oh, who's talking at 4:00?
Allard and his students.
Oh, okay.
How many more slides? Just count them.
Okay. 18 more, thank you. Okay. But
I think you should do the important ones, but I don't think you should take another half hour.
Yeah, Okay, so how about if I just take like 10 more minutes? Is that will
Take
that-
the important slides, the one, I
Okay.
think this DBT stuff will be available to
Right.
all the people here, and I don't think it's your innovative part.
Okay. Okay, so let's just do, I'm gonna just do an overview of the skills and then that's all I need to do. Okay, so let's go, can you flip to 30? The one, number 30? Yeah. Okay, so Linehan took these skills, sets of skills, this is from Zen Buddhism, which is,
But which version of it? The Japanese version?
well, actually Vietnamese. I think it's Thich Nhat Hanh. Do you anybody know Thich Nhat Hanh's Miracle of Mindfulness?
Yes.
Yes. So she uses most of the examples are from his book Miracle of Mindfulness, of how to use mindfulness in daily living. So she talks about the states of mind: logical mind, wise mind, and emotion mind, and then the thing that you're trying to do most of all, I believe, wise mind is, so if you think about multiple parts of self, wise mind is usually a stage higher than logical or emotion. I think logic can review or give, it can be used, but you're synthesizing the emotion by using logic, and that brings the emotion up one stage.
I have a comment on
Yeah.
this. There's, in adult development, there's this whole big field of wisdom. And Baltus was the big protagonist of that. But,
As expert knowledge,
right.
which is different than what she's talking about.
Yeah,
here.
but and in Zen Buddhism, it's the same tripart. What's missing from this is the perception. That you have to know that your perceptions play tricks on you.
Well, she does talk about that wise mind can pretend to be, like emotion mind can pretend to be wise mind if you're getting stuck, but you have to look at, and she actually talks about time delay, is that if it's does this behavior hold up over time as being a reward for the whole self? Well, if it does, then it's more likely to be a wise mind than, and it can be hard in the moment to be clear on whether you're in wise mind or in emotion mind. Anyway, so the next one, what skills and how skills. So the first thing you teach clients that are coming into DBT is how to observe and describe and participate in their own life. And what you find is I can assess a lot about what level of trauma somebody is in by whether they can even do observe and describe. They often can just observe and describe something outside of themselves, but internally, I've found that people will just shut down or say, I can't. You know, one woman, we did doing a body scan, trying to go from her feet up to her head, and she said, I have the impulse to run right out of this office right now. So I had to move her back into looking at something outside of herself. And so, and then the main thing is the how skills. So this is where the responsibility piece comes in. Non-judgmentally, one-mindfully, effectively. What I've found is it's far more important. I try not to use judgment at all in the old way of using judgment. I use judgment in was this effective? Did this work? Was this helpful? And acceptance of where the person is at the moment. I mean, you know, reality is, whether we like it or not, we have the president that we have. We have to live with him. We have to be effective in our country with this person. So that can be the same thing with your boss, with your, you know, it's better rather than to say it shouldn't be like this, to do it is what it is, and how can I respond to it in such a way that maybe will change the environment in the long run for the better. So that's effectively, and that comes straight out of Buddhism work.
May I ask you one question?
Sure.
I'm not sure I understand what you mean by one mindfully. one goes the other.
Okay, so it should be, the full skill is one mindfully in the moment. So when you're in this present moment, so it's literally what my Thich Nhat Hanh talks about is when you're walking, walk. When you're eating, eat.
So with that person, are you in that moment, together in that, is that what you mean by one mindfully?
One mindfully in the moment but it also can be you alone with yourself.
Okay.
One mindfully. So if you're finding that you are trying to do 5 different things at once and your attention is
Oh, I see what
divided,
you're saying.
you're not
Okay.
being one
Focus.
mindful.
Okay.
Or if you're doing something and you're interrupting by thinking about what the meaning of this is to your life and that you're a failure, you're not in the moment. You have to be in the moment, experiencing what you're doing, not some
Yeah.
judgment of others or
Like
whatever.
the Zen of Tennis, or did you ever see that book, The Zen of Tennis?
Oh, yeah.
It's about just playing tennis and being in your body. You're fully participating one mindfully versus having these thoughts. Yeah, go ahead. Did you
Yeah,
want?
I was just wanted to add what Michael was kind of touching upon, that usually when you do things, you're not fully into it. You have the tendency to think of the future, think of the past, and
Right.
having different thoughts
Right.
going at the same time, right? And that one, like,
And you're
mindfulness
judging the
itself-
value of what you're doing.
Yeah, and you just have to sit down.
I'm always thinking about lunch when I'm orienteering.
Me too.
Okay, so I'm just going to go through the different modules. So the DBT, the next one is can you just put the next slide? So this is the interpersonal effectiveness. It's basically teaching skills on how to ask for what you need or say no to someone. So those are the two sides of the coin. You describe, express, assert. And then she adds reinforce in there as far as say, so if you're asking for a raise, you can talk to your boss about, and it would be really good for the company because if I feel better about my position, I'll be able to bring in more business and I'll be able to raise revenues, so that it'll be reinforcing that you give me a raise as well. And then how you do it is mindful, appear confident, negotiate. I'm not going to go into details on these, but why don't we skip to 35? Go to slide 35. Yeah. So then, distress tolerance is the when this is when you're in that amygdala hijack, doing, and some of it is what you were saying, Michael, about being able to just go to look at things that get you out of that emotional state. So you can do concentration on a hobby, project, contribute, compare, do something that will create a competing emotion. So if you're feeling sad, watch a funny movie. Feeling nervous, and there's actually one of the emotion regulation skills is called opposite to emotion action, where if you know that the emotion you're having right now, you're continuing to feel sad, but there's nothing you can do, a person you love has died, you don't want to spend your whole day in sadness, you can decide, okay, I'm going to put away my sadness for this time, and then I'm going to do an opposite to emotion action, which is maybe trying to feel happy or and then I'll just say something, I want to go to willfulness versus willingness, because the will is, she does, Linehan is one of the few therapists, psychologists that talk directly about will. I know that, Bernstein talked a lot about will, but she talks about willingness versus willfulness. So when you're willful, it's that regress, childlike state saying, I don't care what happens. I hate my boyfriend right now and I'm so mad I'm going to go slash his tires. And then willingness is like, that's not a good behavior. Be willing, tolerate the pain. In AA, they talk about pain is the doorway to a new life. So willingness is the willingness to feel the pain that you have. And Linehan also talks about pain versus suffering. So suffering is pain plus fighting the acceptance of your pain. Whereas If you have pain, you have pain. Nobody can take away pain. It is what it is. But adding suffering is the unwillingness to accept your pain. So anyway, emotion regulation is the last module. Not that one yet. Okay, so then there's a, so I gave that example of the person who got a flat tire, dangerous and scary, loneliness, they would help, I should be dead. So basically, emotion regulation is check the context, does the emotion fit the facts? She has a little tree that you go through. If the emotion fits the facts, well then it's justified and you should act in accordance with that emotion. If the emotion doesn't fit the facts, then it's not justified and you may want to use opposite to emotion, action, or problem solving. Okay, so then this is my last one, the 39, and then we won't get to case examples. I kind of intersperse them in a minute. So the life worth living is what you say is the goal when you make the person commit to the therapy. So you're basically in the modules have to do with confusion about self. You want to decrease that. You want to increase mindfulness, decrease impulsivity, increase distress tolerance, decrease emotional instability, increase regulation, decrease interpersonal problems, increase effectiveness, and then finding a way to deal with patient and family dilemmas, and then walk the middle path, which is the Zen thing about finding the middle. Okay, thank you very much. Any quick questions? Since we know we have another presentation.
No, we're gonna have a break first. We
Okay.
have to, you can't
Take
do.
a few minutes break. We
Okay.
have plenty of coffee, tea, fruit,